Okay, buenas tardes. Viva Chile! Yeah! And viva Australia! Woo! Gracias. Okay, now back to English. Thank you very, very much for the wonderful, warm welcome today. This is very exciting for me to come to see my sisters and brothers in the Southern Hemisphere. Southern Hemisphere of the world is the best, of course. So thank you very much to BD for putting on this extremely nice meeting where we have the chance to come together. So here is our website for the Avatar Group, and if you want to read any of our publications, we always put them up there free to download, so you don't need to go through any library or journal. And our group is based in Australia, but we are very active around the world. And we're really just a group of people who are obsessed about vascular access. So we really have this dream that patients don't need to have these terrible complications. Now, we're very focused on the clinical area, on the hospitals and the health services. So even though some of us are very academic PhD nurses, we're still in our heart every day. We are walking with the nurses at the bedside, and we try to make the best evidence for the evidence-based practice. So our focus is really wherever the patients are. So we focus on peripheral catheters, central catheters, arterial catheters, ports, anything that a patient requires, and also right across the lifespan, right from the babies right through to the children with vascular access needs and to the adults. Because, of course, people grow, they change, and they need vascular access throughout their life. Similarly, we focus across the clinical areas because a patient doesn't just go to one clinical department in their hospital stay. So we think it's important to research right across that spectrum of emergency, cancer, renal dialysis, intensive care, even the community and outpatient setting. So because I'm at the end of the day, there's been many excellent speakers already who covered a lot of my best material, so I will try and move quickly through some areas that I think have been covered already very, very well. So peripheral catheters, this is our latest systematic review with 75,000 published peripheral line complications and failure around the world. And we find that on average, the global rate is, in fact, 1 in 3 patients have peripheral line complications leading to failure of the device. So, as has been said, most of these are not infectious complications. Most of these are, in fact, the phlebitis, the pain, the leaking, and so on. But of course, there's a small number of infections, both local and bloodstream, and these, of course, are highly important to prevent. As far as central lines, we have a little bit better results, about 1 in 4 patients on average. When we put all the published data together worldwide, we'll have some form of complication leading to device failure. Of these, again, it's not the infections that are the number one problem, it's actually these other complications like occlusion. But interestingly, many lines are pulled out because of suspected infection, like 17% of intensive care lines, even though actually only a very small number are confirmed. So again, an example of waste that we could probably target. Now, the cost for us, we recently published a study looking at the economic burden throughout our entire state of Queensland, Australia, which is the green part of Australia for anybody who hasn't studied the geography very, very close. So our population of our whole state is about 5 million compared to your 18 million for your country. And we found by getting all the purchasing data from our hospital sector that we use nearly 3 million vascular access devices per year of any type. So that's more than 1 for every 2 head of population every year. Now, almost all of those, 98%, are peripheral lines. This is by far our biggest use. And we also know from our research that 25% of peripheral lines never make it into a patient's vein. We buy them and they end up in the rubbish bin because we can't insert them. A slightly better figure for central lines, but still about 1 in 5 of each one we buy in our hospitals never makes it into the patient's veins. And of course, there is a huge cost for the health system, both the products and the people time. Now, just to bring it to a one hospital example, this is my hospital. It's a 900-bed academic hospital. If you see this flowchart up the top, we purchase every year 200,000 peripheral devices, and this flowchart shows what happens. So 50,000 end up in the trash because we can't insert them into our patients. Of those that do enter the vein, you can see on the right-hand side, we lose a huge number through these non-infectious complications. Patients have 1 or more of these. And on the other side, you see the infections, a small number that are, of course, important and deadly potentially. But you can see in the green, we're really only managing to use less than half of the ones we buy for the job we want. Now, I know this because I'm researching in this hospital, I'm walking in there all the time. But does my hospital know? Does the executive committee know? Does the chief executive officer know? So this is the reality. This is the problems that we actually have in our hospital every day. We have all of these complications, including infection, in all sorts of device. But what problems do we measure? Just one. This is all that my executive thinks happens to catheters. CLABSI, so central line associated bloodstream infection. They're only knowing about one problem and they're only hearing about one device. So perhaps we do have about 1,000 CLABSI every year, but we have about 125,000 other types of peripheral and central line failure that we're just not measuring at a system level. So I love this quote which says, if you can't measure it, you can't improve it. And I think this is the most true for vascular access because many hospitals, even hospitals where I think there is good nursing, if I ask them, how are your peripheral catheters, they say, oh, they're good. Yes, some of them have complications, but we don't have any big problem. But we know that that's not true. So the first step in fixing a problem, we have to know that we have the problem. And in vascular access, we're always wanting to test new products, new practices, and how can we know if they were worth the effort of the change, if they were worth the cost of buying a new product, if we can't measure it. So let's talk about key performance indicators, or KPIs. So these are used in many other aspects of healthcare. And how many should we even have in vascular access? Do you think we should have more than one? See? So when I speak to the vascular access specialist, they say we need to measure a lot of things. But when I talk to the hospital executive, they say we already have one thing, CLABSI, we don't need anything else. So I don't think we can have all the things that the vascular access team wants to measure as KPIs, but I think we need more than the one. So what number is the right number? Generally for KPIs, we only want about 5 maybe things that we can report every quarter every month up to the senior managers to try and push the message to them that we are or are not providing a safe, quality service. So, given we have a lot of data, I'm sure you have databases about your central lines or your PICs, but how many of those should actually become KPIs? And what can we learn from other safety industries? So this is a broken ladder. So on the left, we have a ladder that is broken. It's potentially a dangerous problem. And in the middle, we have somebody who does have a small accident, but it's not a serious harm. But if we go over to the right-hand side, the person could in fact have a serious injury. So the concept in safety is that when we have poor outcomes that are important, we want to actually go backwards and measure those unsafe conditions which allowed the accidents to occasionally happen. So let's think about vascular access. Patients can die from vascular access. They can die from bloodstream infections. But it could be the dressing that is wet, that's bloody, that it leads to the risk situation. So we have to think like this to develop our KPIs. So KPIs, or quality measures, can be either outcome-focused or process-focused. So the outcome are the sort of things we could measure if we looked at the patient's medical record at the time the catheter comes out. On the other hand, a process measure could happen at any time during the catheter dwell. Now, I like this life cycle approach whenever I think about a catheter. So these are the stages that happen to a patient, and we think about the device choice, which catheter, which device is correct for this patient. Then there's the insertion procedure itself. Then there's a longer period where we have to keep that catheter functioning. And finally, we need that device to be removed safely and on time when therapy is complete. So let's also think, what do we want? Let's get really basic. When we put a device into a patient's vasculature, what are we trying to achieve here? I think we want it to be inserted on the first attempt. I think we then want it to keep working and not to get an infection. Next, we want this whole thing to be comfortable for the patient. Next, we want this patient to be involved in their care and to help us to do the right thing and to keep them safe. Lastly, we want to take the line out when it's no longer needed. Is there anything I've missed here? It's pretty much the basic concept. I guess from the institution's point of view, there's one more thing that they want to have is some documentation. They want to make sure that the catheter is recorded in the medical record. Okay, so let's go back to the KPIs now. So if anything is going wrong at any stage of this device life cycle, we can lead to device failure. So remembering that device failure was any of those complications that cause the device not to be used. If there's poor choice of device, if it's poorly inserted, if it's poorly maintained, and if removal is late or it's unsafe, this can all lead to device failure. So I think this should be our first outcome KPI for catheters. It should be device failure. And we've been collecting this for a number of years in our research trials, and we find that this is a measure that's easy to obtain from the records, and it seems to be sensitive to changes in practice. So a reminder that you just look at the device once it's removed, as in you look at the record, you talk to the patient. Were there any complications on that day? For central lines, it's exactly the same, except we also include any reversible complications during that whole period of dwell. we add the reversible complications because central lines are used for much longer, and some of the interventions to reverse complications, like giving the alteplase to dissolve clots, or like patching a fracture to the line, are very expensive, and obviously if they don't happen, the line will fail. So otherwise, it's pretty much the same. We just run through the chart and we find out why the catheter was removed. For peripheral lines, we tend to say phlebitis. For central lines, thrombosis. And we also look at pain because we find pain is a very good predictor of both phlebitis and thrombosis. Now, going back to the start, if you remember, in our hospitals, in my hospitals and worldwide, we have these levels of device failure. And we can tell our executive this all we like, but it's not really until they have a benchmark where I tell them, do you know, in Chile, they have 20% lower failure, or in the hospital down the road, they have lower failure. It's only then that they start getting really interested in helping us to reduce this failure. So the next step is setting benchmarks, setting goals of what is acceptable or achievable success. So imagine 5 or 10 years from now, if we knew that the global standard was no more than 10% of peripheral lines fail and no more than 5% of CVADs. Can you imagine what a powerful thing this would be for our patients? But device failure is not the only outcome we need as a KPI. Health systems across the world are moving to patient-reported outcome measures and patient-reported experience measures. So the outcome measures being the effect that the patient says that procedure had on them, and the experience is how they say it impacted them during the procedure. So these have been validated in many other settings, like surgical procedures, but they have not yet been developed or validated in vascular access. But I think we can have a pretty good guess at what some of these will be once we develop them. So PROMs, outcome measures, are typically pain and anxiety. And I think patients in vascular access definitely would say that they want to have less pain with their devices. As far as the experience measures, there's a couple of hints in the literature so far that patients would say they want us to avoid multiple insertion attempts for their peripheral line insertions, and they want us to communicate with them effectively and positively during the procedure. So let's say that we are going to today take our PROM as the pain and our PREM as the single attempt at insertion. So now I'm finished on the outcome KPIs, not the whole talk, just the outcomes. So I think we need 3. I think we need to look at the multiple insertion attempts, which would involve real-time auditing of insertion procedures, just like we do, say, for hand hygiene. We would go and audit a certain number of insertions because we can't, unfortunately, trust what is written in the chart. This is the fake news. You know this term. Second, I think we need pain. We use any pain 2 or more above during the dwell of the catheter. And lastly, we need the device failure as our outcome measures. But let's move on to the process KPIs. So, of course, we need to think, what are the key things that predict failure of the catheter? So from a device selection point of view, we like to audit whether they should have had this device for that medication. Each hospital pharmacy has a list of what the patient should or should not get, and if you read the medication record, you can give a yes or no answer to your audit as to whether the patient had the right device. As far as device insertion, similarly again to the hand hygiene audits, I think the audit measure should be, was there an aseptic insertion procedure? And the only answer that would be recorded in this audit would be yes or no, because if any one of these steps of the insertion procedure is not done correctly, then the whole thing is invalid. It's very important for KPIs that you can record it as yes and no, because the people in the executive level are not able to read very complicated data and charts, am I right? We have to make it very simple for them that 50% did the right thing and 50% did the wrong thing. Now, as far as device maintenance and device removal, this is, I think, very exciting. We've developed a new tool which aims to target both of these and can be used both as the audit tool and as the bedside decision-making support tool. So we came to this because all of the phlebitis tools that are out there already, and there's 71 of them in the literature, none of them have been well validated. In fact, only 3 have any validation testing. And we know that because they focus on phlebitis, they ignore all those other things that are important, like poor dressings, poor hub decontamination, and so on. So we've worked very hard, and this tool is called I Decided. I think you can say it in Spanish very nicely as well. And this is led by Gillian Ray-Barul. She'd be happy to hear from you if you're interested in testing this in your hospital. And basically, it's a decision-making prompt that nurses can use to try and make a consistent, good decision. So the first step is to decide, does the patient have a catheter in the first place? Because we know that many peripheral lines are forgotten, or actually even sometimes go home with the patient. Secondly, is this PIV necessary? It's very important that we remove these devices as soon as they're not needed anymore. And it's also important that if the patient could be moved on to oral antibiotics instead of intravenous antibiotics, that we prompt the nurse to make this decision with the physician. Thirdly, is this catheter even still working? This is a big problem with many catheters that have not been flushed, they haven't been assessed for function. The next one is still the traditional vein assessment, site assessment, like a VIP or an INS. So it asks, is there any poor function at the site, pain, redness, pus, and so on? I stands for infection, so infection prevention, reminding about hand hygiene, about antiseptic decontamination of the hub, and so on. The next one, D, is for dressing and securement. Is the dressing clean, dry, intact? And has the tubing been very well secured? And I emphasize very well because we are finding that no dressing well enough secures the line. We have to also have some form of secondary securement, good quality tape, devices, and so on. The next one, E, is for educating the patient. Does the patient even know why they have this PIV? Studies have shown that if the patient does know why they have it and what the plan is, they're far more likely to have that removed when it's time, and also that they are more likely to report if there's any complications to the nurse. The last one, D, is about documentation. Of course, we need the nurse to be encouraged not just to assess, but to make a decision about what they will now do. Should the catheter be continued? Should the dressing be replaced? Or should the catheter be removed? And these are really the 3 things we're trying to push people towards some action. So back to our KPIs. So look what we have now. We have 3 process KPIs, we have 3 outcome KPIs, and they cover this entire cycle of the device life cycle. So I think they will also give us what we want. I think they all link back to cover on these first principles of what we're trying to achieve with our peripheral IV catheters. Now, how would this actually practically work? Maybe you are thinking. So what I would do is I would pick one of these each month, or you can do them all if you have a lot of time. And I would then go and audit the patients. Now, how many do you need to do? Of course, ideally, you would audit everyone in your hospital. This is never going to be possible, but what you can do is take a sample. It's important this sample is somewhat random, though. If you just go and audit your favourite ward where the nurses are friendly and you like them, you're going to get very different results than if you get a good representative sample. So we recommend that if your hospital is, say, 200 beds and you want to audit 25 patients, you would divide 200 by 25, which gets 8. Then take a printout of all the patients in hospital on one day and make sure you audit every 8th patient. That will stop you from deciding who you audit, and it will force you to go into emergency department, oncology department, surgical, medical. This is just a suggestion, okay, to get you thinking. You can tell me later what you think. And ultimately, what we're trying to do at Avatar is to build a global computerized registry where once we get agreement on what these KPIs should be, so once we know that Chile and Australia and US and everywhere agree that these are the things we want to measure, we want to know what the average number of insertions attempts is to place a PIV, then we can actually get some very good data to feed back to hospitals about what is my level of KPI compared to other hospitals, compared to my country, compared to my region and the world. So this is like a bit of a dream, but we have also made some very practical, concrete steps, and I hope that we can work together on this. Now, let's go back to the OMG study, which was published this year and done a couple of years ago. Can I ask who was in the OMG study? Was your hospital a member? Marcella, yes? Anybody? Okay, so this was a very big study we did about processes of care for peripheral lines, and we managed to do this with 40,000 patients, 409 hospitals, 51 countries, 15 languages, and we now have a very big database with 4 million points of data. So the Latin America, we were very happy that we had 10 countries participate. It was fantastic. And thank you to Marcela and to all the other Chilean hospitals that are not here today, but they did a great job. Now, the chief investigator or the coordinator for LATAM was Laura Alberto, who many of you may know. She's from Argentina and she's an intensive care nurse. So I also want to say muchas gracias. It's really fantastic. Now, here's some pictures from some of the hospitals in LATAM. What they did, they got a team together of volunteers, right? Nobody was paid in this whole study. Can you believe this, what we can do with our power? Yes, it's amazing. And it wasn't that hard for each one person, but between all of us, this is what we can achieve. So they got these teams together of volunteers, which was also a good way to get champions and increase support in the hospital. And on any particular day, they went around and audited PIVs in the hospital. Now the findings, here's the findings. There were a lot of things that came to light which tell us that we need to work on these. So 14% worldwide of peripheral lines were idle. They had not been used in 24 hours. There was no medication or fluid prescribed in the chart. This patient just had an invasive device, risk of infection for no reason. It should have come out in most of these patients. Now, phlebitis, 10% of patients had a painful, symptomatic IV. Why was it still in the patient? Another 10% had some form of malfunction, so often like blood in the tubing. A shocking 75% were placed in an area that we don't want the catheter to be. So particularly the elbow, the inner elbow, or the wrist areas where the catheter will fail. We also saw a lot in the hand, which is fine if it's for a short procedure, IV, but if you need to give infusion therapy for a few days, the hand is not going to work for you most of the time. Dressings, 1 in 5 patients' dressing was not clean, dry, and intact, so another infection risk. And the rates of documentation, both for the daily assessment of the quality of the catheter as well as whether the catheter had been documented at all, that it had been inserted, were very poor. So the overall priorities really for all of us in the world were really to improve our assessment and our documented assessment. They were also to work on these idle PIVCs. In my country, it was 50% were idle. It's very bad. But I have to say, in LATAM, you were actually very good. You were one of the best in the world at taking your IVs out when they're not needed, so well done. Symptomatic PIVs, there's millions of patients worldwide with painful PIVs. This is on top of their operation or their sickness that they already have, so why are we not taking notice of this? Again, the state of the dressing and securement was really, really poor. Now, Latin America, we had some special priorities based on the data here. This was about 2,500 patients we had here. We did see a lot more 18-gauge use in LATAM than we did in the rest of the world. 18-gauge, of course, takes up more of the vein, is more likely to irritate the vessel, and can cause phlebitis and occlusion. We need to, of course, address in some countries they were not even using a sterile dressing, they were just using non-sterile tape, which is an infection risk. And we also need to address the mindset that the dressing is enough to secure the catheter. It is not. We have to have some good quality tape or a device or some sort of stretchy, soft bandage over the top to keep that line in. And the last one was there was quite a common rate of blood sitting in the IV tubing here in LATAM. So what can we do with this with care bundles? I'm moving on to now what can we do about some of these problems. People ask me often, what is the care bundle for peripheral lines? So remembering that a bundle of care like the CLABSI insertion bundle that they developed with Dr. Pronovost up in Michigan in USA, what it is a way of putting a small group of interventions that have very good, high-quality evidence, put them together and say to the hospital staff, you have to do these every time, every patient, unless there is a really true reason not to. So one thing about bundles are very, I don't know, sexy, can I say that? With what we say at home is very fashionable at the moment. So bundles themselves aren't going to be magic or a miracle and fix your problems, and they don't keep working necessarily. But they can work if there's a genuine commitment to change in the facility, and if you look at multiple ways of enforcing them and changing the culture and the workflows. So remembering that we only want a small number, 3 to 5, because it's impossible to force people to do 20 things, let's just pick the most important, and they have to be very evidence-based. They can't just be a good idea. So thinking about this pyramid of evidence, of course we prefer the bundle items should come from evidence at the top of the pyramid where we've got, say, 20 randomized trials on the same topic in different hospitals, different countries, to try and work out if this is something that really will help all of the time. But that unfortunately is not we are not so lucky. There are not so many published studies yet, so we have to just use the few that we have. In the review that Mari Takashima did for us, she found there were only 2 randomized studies in the last 10 years that actually found a significant benefit in vascular access for PIVCs. So the first one was a study that was done in Spain and published in 2014. And in this study, they randomised patients to either have the integrated PIV with the flatter profile and the built-in tubing against a traditional separate tubing and round-barreled catheter. And they found that the integrated device was associated with a statistically significant 1 day longer function. Now, 1 day might not sound much, but actually think of the average dwell time is really only 2.5, 3, 4 days often. So if we can get 1 more day out of a device, for many patients, that means that will be their only device that they will need. So I have to tell you, in Australia, we are currently doing a randomised study of our own on this device, and we were successful with a grant from BD to do this. But the research itself is controlled by Avatar. It's an independent project. And the reason we're doing it is because we got excited about this Gonzalez-Lopez paper, and we thought we wanted to test it in our hospitals and see if we can get the same results. So I said there were only 2 things that have been statistically shown to work. Here's the other one. Oops, or not. Yes. So this study was published in Annals of Emergency Medicine. They looked at applying the tissue adhesive skin glue. It's a cyanoacrylate skin glue. It's very similar to the one you buy at the hardware shop. And they applied just 1 to 2 drops on the insertion site under the hub of the PIV, and then they still put a sterile dressing over the top of that. Now, they found 10% significantly less PIV failure, which was a very good benefit, but I would say that this is a technology that is still very expensive. It's tricky, it's a little bit difficult to apply, so it really needs to only be in the hands of the specialists to apply, and also you wouldn't use it unless this is a patient that needs definitely a few days of therapy. You really want this line to stay working. This is not something you would give to every patient. Okay, let's look at the systematic reviews, which, if you remember, they sit above the randomised controlled trials. So these are looking at when there are multiple randomised controlled trials, and you can start to get a feeling for whether the evidence is true. So there were only 2 of these as well that we can use to guide us. The first one was about vapocoolant spray. So this is a gas-based spray that you spray on after you've decontaminated the skin. It just evaporates completely, and it makes the area very cold. So you might have seen it used in sports injuries. They sometimes spray people when they fall over on the soccer field. So in this, there were 9 randomised studies, and patients had a significant reduction in the insertion pain if this was used. The majority of patients said that they would like to have this again the next time they have a cannula, but some of them said they didn't like it. So it definitely can reduce pain, but it needs to be still a patient choice involved in using it. The only other systematic review with statistical results was this one, which was done by our group, where we looked at the 7 randomised studies testing removal of PIVs routinely every 3 days versus based on assessment. So assessment meaning as soon as the treatment was completed, the catheter was removed, or if there were any complications, the catheter was removed. And this found that there was no difference in phlebitis or occlusion or infection, but there was a significant reduction in patient procedures, as well as, of course, a massive increase in cost savings and time savings for the staff. So we don't have a lot of randomized trials and a lot of systematic reviews, but we can look at cohort studies where these have been done prospectively, so they decided to do the study and then collected the data as opposed to the other way around, and where they've done a good multivariate analysis, so where they haven't just looked at size of the catheter, smaller versus bigger, but they have also built into the analysis the effect of age, the effect of the insertion site, the effect of what fluid you put through there. So in other words, it's something that is a much deeper analysis. So these are the 5 things that we see recently predicting failure. So again, insertions at a flexion point like the elbow, hand or wrist. Small catheters, small gauge, smaller length tend to be more easily dislodged. Larger gauge catheters tend to cause occlusion and phlebitis. Securement, again, if you don't have some form of securement as well as the dressing, the catheter statistically is more likely to fail. And lastly, an interesting one, but we see that the more times a PIV is accessed, either for giving a medication or a flush or an infusion, the more likely that catheter is to fail. So initially, what do? Should we not use them? No, that's not right. We have to ask, how are these medications being delivered? We see in our laboratory that the pressure of the injection is very important. So if the medication is pushed in too quickly or the flush, we see the vessel immediately, the inside of the vein starts to swell. And probably many cases of occlusion of PIVs are not a clot, but what they are is the vein swollen shut inside. So again, if we look at our dilution schedules, make sure we are diluting enough, that we're gently flushing, that we're gently inserting medication. This should take away this risk factor. Finally, what about infection? When we can't do a randomized study of non-aseptic technique, that would be unethical, just like smoking. So in these cases, it's considered the best level of evidence to use epidemiological evidence and basic science. So we know how bacteria grow, we know bacteria can cause disease, so clearly aseptic insertion, decontamination of the needleless connectors, hand hygiene, these things are all, of course, should be in our bundles. So, bundles. I think we can't just have one bundle for PIVCs. I think we need an insertion bundle for this day that the catheter goes in, and we also need a maintenance bundle for all of those days ahead while the catheter is in. Now remember that because we don't have to take PIVs out anymore routinely, they can be used for much longer than sometimes we ever thought. So we see some patients, we can use our PIVs for a month, sometimes a bit more. Some patients, their devices always fail on day 1 and 2. Some patients just seem to be able to tolerate longer dwell PIVs. So we should look after these devices, we should keep assessing them and monitoring them, and we should take them out when they're not needed. But on the other hand, we actually see they can be used for much, much longer than ever before. So my insertion bundle, I would suggest, should be ANTT, hand hygiene at insertion. Offer the patient the vapocoolant spray before you insert. Decontaminate the skin. We recommend alcoholic chlorhexidine in line with the central line and let that dry. Choose an integrated PIVC unless you're just doing a procedural or short-term catheter. Use 1 or 2 drops of tissue adhesive to better secure that line unless, again, this is a short dwell catheter. And as far as maintenance, the maintenance bundle, guess what? Remember the KPI for maintenance? Here we are again. So this tool is designed to not only give you a bundle where you can ensure good care throughout the patient's dwell, it's also designed as something you can audit against and then report up as a KPI to your management, to your executive, as well as feeding back to your nurses to try and say to them, hey, we're going okay with our infection prevention, but we really need to work on our dressings now. And lastly, of course, is our invitation to please collaborate with us in Australia, as well as with Marcela here in Chile, and through Sao Paulo in Brazil, and the rest of the countries in the vascular study. We think this study will be extremely important to give a really deep knowledge of what is happening throughout these countries, both in the public, the private, the rural areas, the small hospitals, and the big academic hospitals and city hospitals as well. So thank you, BD, for your help in supporting this study. Thank you to Marcela for running this study, and please come and see her.